Paper is due Friday, midnight. If you're a little late, like Saturday at noon, probably not a big deal, but if you got it, turn it in. Let's make sure everybody is aware of the rubric on the first article. Make sure you're real clear on what the author is doing. They're trying to connect life insurance and your asset allocation strategy. Make sure you state these two things and I'm going to link them with human capital. Make sure that's real clear. Have the formula in there. That's the give me points. I would probably on the human capital, put the graph of it in your paper. And then magnitude, volatility, and correlations, people lose the most points. So
In magnitude, you said?
I'm sorry,
You said magnitude?
magnitude. What did I say? So I would put those three together. Remember, magnitude is not just your training and education and your income, but it's the present value of that. So that's where volatility and correlation comes in. Your discount rate is determined by volatility and correlation. Higher volatility, higher discount rate, lower human capital, so less need for life insurance. And you want to be more conservative in portfolio. Just remember that. Higher correlation to the economy and the stock market, higher discount rate, lower human capital, lower need for life insurance. You want a more safe, low risk portfolio, right? That's where students lose most of their points is on those three. Any questions on those three? The key really is the discount rate. If you get tied to discount rate, it's a pretty easy discussion. The rest of it is pretty straightforward. Be careful on the human capital and optionality that you're really clear. They make I think a pretty clear argument. You really just got to reword it in your own words. If you bring in the argument that young people can buy more in stocks because they have more time, that's really not their argument. The entire argument is young people have more human capital. It looks like a bond, so they can buy more stocks. That's the argument. The argument that they have more time, that's the time diversification argument. It doesn't really work mathematically, but you hear it a lot from financial planners, but that's not the point of this article. This article is human capital looks like a bond for most people when they're young. So when they're young, they should invest more in the stock market. Make sure that's real clear. The forces is very straightforward. It's just a list. And the reason people don't annuitize is real simple, except for he gives one before he does his list. Make sure you have that one in there, that people are just addicted to stocks for the long run. And that's one reason. And then this list right here is where people lose points. The recommendations, make sure you're really clear. You got to put it in your own words and you're real clear on what they're saying. Some of those in the list are a pretty long paragraph, or he may actually be giving you more than one thing. So just be real clear. Don't just summarize the first sentence and think you got it. Read the whole paragraph. Make sure you got everything that they're recommending. Any questions, comments? You probably had it written 3 weeks ago, so now you just got to clear it up. So, all right. Thank you in here. Anybody else? And oh, Jackson. I think I got Jackson. Yeah. Oh, so helpful today. All right. I think we're getting really close. Finish up these articles. We got a few articles on AI. We may not go into in detail, but this is a fairly recent article. So what will AI bring us? So in the technology as a solution, I would put the AI stuff in there. Here's a good article you can pull some stuff from. Better diagnosis, more personalized support for patients, faster drug discovery, greater efficiency. There is some sense that AI is having a bigger impact on healthcare than a lot of other industries. A lot of industries, healthcare is using it without much fanfare and much articles, but it seems to be doing it more intelligently than others. AI could save hundreds of thousands of lives each year, could save money. So, that whole paragraph could go into your technology, or you can summarize that. Enhanced diagnostics accuracy, disease tracking, improved prediction of patients' outcomes, better treatments. All of these he wanted to create like a list of where could AI influence. You can just see it there. Better diagnosis, save lives, lower costs. It's the ultimate solution. Boost efficiency by taking tasks on, such as medical transcription and monitoring patients, streamlining administration. I mean, it's just all over the place. These two paragraphs, I'm not going to copy and paste them, but you may want to copy and paste these into the technology because there's a lot packed into these two paragraphs that really summarize what could AI do. In a paper like this, since AI is such a hot topic, having an entire section just on what AI could do, I think would be really powerful for this paper because it is out there. There's a lot of resistance. Doctors don't like it. Hospitals don't like it because if you save money, they don't make money because they charge based on what they spend. It may be speeding the time it takes for new drugs to reach clinical trials. New tools, including generative AI, could supercharge these abilities. So this is coming out of the, that's why I say this economist was so great. They do a technology quarterly, and they chose their technology quarterly on AI and healthcare. So it's just a really, really good economist. Here's why it may work and why it may not work. Healthcare needs evidentiary, has high evidentiary barriers, and AI can actually help with that. But how quickly would it do? You know, you got the regulatory side, you got the incentives, obviously. We'll see if AI can actually do it, but there is the excitement we talked about before when you're seeing Alphabet and Apple and Costco and those firms getting into it. Here's another quote on the bad quality in healthcare. Roughly 800,000 up in the problems, the quality, low quality care, roughly 800,000 Americans suffer from poor medical decision making. I think the big advantage of AI is there are 300 and something million people in the United States, especially Medicare has a lot of data. AI is great at going through that data and figuring out why did this pill work for these people, but it's not working for these other people? What's the difference in them? And AI is going to figure that out a whole lot easier than a few doctors that are seeing patients a few every day. So here this article is talking about what you may not talk about the regulatory side. Surveillance of adverse events, the continuous amount of algorithms, sure they remain accurate, safe. So, you know, there's some fear letting AI go. So he's talking about the incentives. AI promises to cut medical costs by assisting or replacing workers, improving productivity, reducing errors, and flattening or reducing spending, all while improving care. That's definitely needed. The healthcare systems are set up to improve care, not cut costs. I'm going to put that. I love that one. Inefficiency is encouraged. I just like that. Back to the incentives. This is a system that, unlike every other business, this is a business that has no incentive to cut costs. No incentives for productivity. Why? Because if they cut costs, their revenues come down. It's just really straightforward. So is be resisted by patients, by medics, though AI may be able to triage them over the phone or provide routine results. Patients may not be up for that. So I did my doctor's appointment Friday by phone. No, Monday. It was a 10:20 appointment. He came on the phone at 11:20. This is how bad the system is. So I told them I'll just go to Quest and send the blood test over, and then I'll meet by phone. So I'm on the phone with him. He says, "Yeah, we need to get you another blood test. You haven't had one since March." Said I had one 2 weeks ago or a week ago. So they didn't have they didn't have the data. So I'm talking to this guy who can't tell me anything because he doesn't have the blood test. He's frustrated. It's like, how can I not have it? So I went through all of that, and then he said, "I'll have to get back to you." So I waited an hour. But the nice thing was I was waiting an hour at home, waiting for his phone call. versus sitting in the waiting room with nothing to do. So it was still better. It was a better process. I like that better, but it still had many problems with it. So, many health systems are set up to reward the volume of work. They have little reason to adopt technologies that cut number of visits. I'm going to put that under inefficiency is encouraged. You saw that in the video where, this hospital say, yeah, we're doing things better. And that's actually cutting our revenue. Unless governments can change these incentives, and how can government change it? It's Medicare. Medicare is the gorilla in the room. Medicare is so massive, so many patients, so much money. Medicare can drive this. It was 20 something years ago. We were talking about making healthcare much more efficient. And I was in this big conference room with all these people, and they just canceled the conference. They said, until Medicare decides to set the rules, we're wasting our time. Because no one's going to do anything until Medicare says they're doing it. And Medicare is not set up. So it's got the government bureaucracy versus the industry bureaucracy. Yeah, it's a mess. So it's not only government changing the incentives of the healthcare system, it's changing its own incentives. You got to incentivize Medicare to do better. All right, here's some articles on the efficiency gains in medicines. So more wearable devices, blood pressure cuffs, thermometers, oximeters. I'm not sure what those are. England reached 10,000 virtual beds. This is another technology, virtual beds. It wants to actual beds to about 140,000. They want to have 24,000 of them. 14 beds are being added daily. What's a virtual bed? So essentially you're at home, but you're hooked up to stuff and they're monitoring you from the hospital. It's a lot cheaper. Virtual wards to a hospital system that is chronically short of real beds, especially during the winter. Virtual beds can be created far more rapidly and cheaply as patients seem to like them because they prefer to stay at home, sleep undisturbed by nurses changing shifts and eating their own food and eat their own food from home. If patients don't go to the hospital, they will not pick up. It's also safer for them. They don't pick up infections. So that's definitely can go under technology as well. So your technology section as a solution should be meaty. You don't have to cover every single thing we talked about. I would have an AI section for you and then add in some of these others that talk about how technology could radically change this industry. Costs are lower, maybe a third lower versus an actual bed. But lack of standardization and guidance on how they should be set up is a concern. So certainly the government, NHS could help with that. I would prefer that, wouldn't you? Wouldn't you rather be hooked up on stuff at home? I mean, maybe worried the dog or the cat's going to jump up and mess something up. I mean, it's not as controlled environment. It's not as sterile, but then you don't have a lot of sick people walking around either. So, all right, this one's pretty amazing. So let's go down to the solution pretty far down. On medical tourism. So I'm going to give you a few examples here. Lower cost models, you could probably put the virtual bed there under lower cost models. So that certainly fits there. But let's look at medical tourism. So medical tourism is it costs you $5,000-6,000 to fly to India, to Costa Rica, or wherever. But the medical care is so much cheaper, it covers the cost of that trip. And the quality is the same or even better. That's what medical tourism. I go to Costa Rica a lot. Costa Rica has become a medical tourist spot. We actually flew a kid from Chile to Costa Rica to have his foot operated on and covered his travel costs just because Costa Rica was so much better at treating him. So this guy's really amazing. I don't know how to say his name, but this guy here, he has cut the price of artery clearing coronary bypass surgery to $1,583, half of what it was 20 years ago, and wants the price to go down 800 within a decade. The same procedure costs over $100,000 in Chicago. This guy is radical. Why he's so incentivized to cut costs? Maybe because he's in a country where people can't afford $100,000 care. Pretty amazing. The chain uses web-based computer software to run logistics rather than licensing or building expensive new systems for each hospital. He's using technology that could go under technology as well. And the quality is talked about in here, but I don't think I'll put that in there. I highlight it in yellow. So he's looking at the system. This is something that hospitals in the US don't do. He's looking and saying, well, how can we do better? How can we be cheaper? How can we eliminate unnecessary work? When I do with doctors, that's just not top on their list. I don't think this article tells you why he's so good at this, why he's doing that, but it's amazing, pretty amazing. What about Thailand? Now, you might not want to go to Thailand. Obviously, they're in the middle of a pretty huge political turmoil. But in all this instability, it has a great public health system. Their healthcare is among the most effective in the world. The average Thai can expect to live to 80, much longer than their regional counterparts, even slightly longer than the average American. I'm going to bring that in. I've never been to that part of the world, so maybe if I need surgery, it does be my excuse to go to Thailand. Last year, 99.5% of the population was covered by health insurance. Remarkably, they've achieved this as a developing country. Its income per person is only $7,000. I don't know how your living time's smaller than something else. I've never understood quite what that means, but probably they mean 89% lower than the United States or something. Even in the middle of the pandemic, its public health bill was 6% of GDP compared to 17% in America and 11% in European countries. Why public health became a priority? So a wave of spending was unleashed on the infrastructure. The government launched a program that required medical graduates to spend the first 3 years in villages. Subsequent governments made healthcare more affordable. The big incentive was an insurance scheme targeting the poor. This was followed by state-sponsored schemes for those working in informal and private sectors. In 2002, the government rolled out a universal health program, offered free healthcare to the poor, and a nominal $1 fee for others. Free, I don't like that word. It's obviously not free, but government provided, paid for by the taxpayer. An equally important feature of the program is its focus on preventative healthcare, something you don't have in the United States at all. Particularly striking is the fact that universal health coverage is not only affordable, but also affordable not just to the people in the program, but to the government. The program is funded through tax revenues, but spending is controlled. Many countries are eager to emulate Thailand. Earlier this year, Saudi Arabia signed an agreement with the government to cooperate on public health matters. But they have the same problem everybody else has. More than a fifth of them are over the age 60s, and doctors are complaining. So every country has people who are just aging. That's old people have a lot of medical problems, but that's pretty impressive, right? You don't hear much positive about Thailand, especially with this last military coup. Oh man, the guy came back, I just forgot his name. But I mean, it's a turmoil. I don't know if I want to go there, but very, very impressive. Same thing with Costa Rica. Costa Rica generally has a very impressive, highly respected healthcare system, but it's a country that's in serious problems. Their debt is rated single B, but for some reason, healthcare is pretty good. One thing I'll say on Costa Rica, while their healthcare system has a good reputation for being affordable to all the people, all the population. That's unless you have something really serious, unusual happen to you. And then you're off on your own. We did a GoFundMe for one family in Costa Rica. They had a special need child, very serious medical issues. And the government said, you're on your own. We can't do anything for you. So if you break your foot, if you need heart surgery, if you need the basic stuff that, thousands of people need, it covers you really well. If you have something unusual, you're on your own. This poor family, we raised like $15,000 for them. Or it would have been just impossible. But so not any system's perfect, but for the general population in Thailand and in Costa Rica, they tend to handle the basic stuff pretty well. What about Walmart as your doctor? Compact facility complete with examination rooms, dentist office, a lab, x-ray tucked into Walmart. Walmart has opened 32 of these health centers in 5 states. By the end of next year, it plans to more than double. What year is this article? 2023. This is a recent thing. I haven't noticed that, but when I go to Walmart, I'm not looking around. I'll put that in our clinics instead of hospitals. Again, I love it. I love seeing a Walmart. Walmart does have an incentive to keep costs down. We already talked about One Medical, concierge practice, Dollar General has set up a partnership with DocGo, which runs mobile health clinics and has launched a pilot program in 3 shops in Tennessee. I mean, any of these can go under that alternatives to the existing system. So we talked about Amazon, One Medical. Here we got Walmart, we got Dollar General. I can't imagine Dollar General being strong in this, but maybe they'll do well. Who knows? They're going to experiment with it. Americans spend a stunning amount on health, roughly 18% of GDP. We keep seeing it flipping between 16, 17, 18. And we spend a lot more than other countries that are healthier and live longer, outpacing economic growth and accounting for almost 20% of GDP in 2031 if we don't fix it. We're fee for service, which insurers reimburse doctors on each visit or procedure. Its advantage is its simplicity. Its downside is it encourages medical consumption, is indifferent to outcomes. Doctors get paid the same amount whether a patient gets healthy or not. I love that whole quote. That's really good. This looks like The Economist again. I'm going to put that under inefficiency is encouraged. I got quite a bit working under that. It could fit under could also fit under focus on treatment over prevention. So either one of those places it could fit. Kind of decide where you're going with your paper. Most payers believe that these payment methods, letting doctors share the upside of keeping patients healthy, would rise. So we'll get into this here. We're going to talk about Porter and these new models that focus on health versus focus on procedures. So we'll see. It's slowly changing. Providers need to invest in technology, but may also need to keep on top of the patients with repeated phone calls and home visits. We'll see what the actual model is going to be 10 years from now. Who knows? Your generation's probably going to see a pretty radical shift that my generation hasn't. It's been pretty static for the last 50, 60 years. All right, we're almost to the end here. Another medical tourism one. This is a few years old. Some come for treatment they cannot get at home. Others to escape long waiting lists for public health care or high prices for private operations. Consumers are incentivized to travel by substantial price discounts across the borders. The average heart valve costs $35,000 in Germany, but only $17,000 in Austria, with little or no drop in quality. A hip operation can be 12,000 pounds in Britain, or euros. In Britain, 10,000 in Turkey, only 4,700 in Poland. I'll put that under medical tourism. Again, you don't have to do all of them, but find some that make your argument. So the way I would write it is, another way people can save money on healthcare is by using medical tourism. Define it, medical tourism is blah, blah, blah. For example, and maybe give 2 examples of how medical tourism actually saves money. And it gets back to there's big differences in cost between countries, although the differences in quality is not there. You're not paying less because the quality is lower. Medical tourism is still hampered by a lack of detailed, reliable information. Yeah, I mean, that's probably what keeps people going to Mexico or Thailand or Costa Rica is if you don't have data on the quality, you're probably a little leery of going overseas. Here's a chart on it. Who's strong and what. Two newest online firms, you might look those up, both based in Berlin, hope to improve matters. They allow patients to search for medical treatments from a large selection of providers, offering clear information about pricing and the quality of staff and services. I'm not sure if you look these up, they would be in English though. So it might not, unless you speak German, might not be that easy. Yeah, it's there. So if you're looking for that thing to research, this could be your entire extra points, just looking up one of these. What do they do? How it works means perfect. How it works? We've done all the legwork to make it very best healthcare available to you. Search for more than 1,000 doctors. Man, that's incredible, isn't it? All carefully vetted. Our priority clinic scoring system. I mean, that's pretty exciting there. Boy. Okay, I want to go check this out. All right, someone put this in your paper. I'm very curious now. That's pretty impressive. And then Medigo. Fewer American patients came than expected, partly because health insurers were not interested. That's the other thing. If your health insurance company says that's out of network, doesn't matter if it's cheaper. So the insurance industry has got to get on board. And that may be an important point to make. So you got to get insurers on board. And that doesn't mean paying for your treatment in Germany. It means paying for your treatment in Germany plus an airline ticket and a hotel stay. It means getting you over there because they're going to save more than that. So insurance industry needs to change their view and partner up with a firm that like the one I just showed you. Yeah, that's exciting. All right, Affordable Care Act, I'm going to skip, but if you want to look through that, these are older articles because not much has been written more recently. But if any of y'all want to make a little bit of a discussion on the Affordable Care Act and how it might address, you could certainly make that your extra analysis. The big deal with Affordable Care Act is this idea of pre-existing conditions and the uninsured. I'm not sure if they give that data in here. Yeah, this is where it should make you upset. One of the things the Affordable Care Act did is essentially overcharge you. If you're young and healthy, you're paying far more for health insurance than you should, so that the Affordable Care Act can subsidize the unhealthy older people. How much, we'll see it, and one of the last things we're going to look at, it's pretty substantial. Yeah, this was interesting. I was reading Rahm Emanuel's book on this. And he admits the purpose of the Affordable Care Act was to eliminate employer provided health care. So what a lot of people were hoping was when the government gave this health.gov, that a lot of employers would say, you know what, you go buy your insurance from the government, the Affordable Care Act, we're not going to offer health insurance anymore. There were some firms that talked about that. I still think that's possible, but it's one of those snowball effects. You need a really large firm like an Amazon or an IBM or someone big employer, Walmart, to say we're no longer offering health insurance to our employees. We're just going to send that money to them as salaries. We're going to send them to the Affordable Care Act. There were people actually hoping that would be the result of the Affordable Care Act, but it just hasn't. The Affordable Care Act has killed off perhaps 2 million employer plans, but that's still not much. They're hoping for 6 million. Second, more people than expected by collect directly from insurers. About 9 million Americans are covered this way. So it hasn't quite worked the way they hoped it would, but we'll see. So the poorer someone is, the more the subsidy is. Those who designed the Affordable Care Act knew that insurers would struggle to predict the health. So the industry started off underpricing, and so there's some hefty increases, but then the last few years, we're actually seeing it come back down. So it's been a learning curve for insurers. Insurers were not sure, insurance, remember, for insurance to work, you have to have data on the risk of the population. Insurers weren't really sure who was going to sign up through this Affordable Care Act. Are these going to be above average healthy people, below average healthy people? And so they had to learn that. So they undercharged to begin with, and now the system is matured and they're actually getting it about right. Yeah. So the death spiral has not happened. The death spiral is healthy people go in and say it's too expensive, so they leave. Unhealthy people go in more because they're getting subsidized. That causes premiums to rise more. Those people who are unhealthy but not as unhealthy, they get out because it gets expensive, and eventually end up with people who are dying tomorrow, and they just need a hospital stay. All right, so I'm going to skip through those. I was hoping to find something in pre-existing conditions. So let's talk about pre-existing conditions. Just talk about it. So we'll go under the problems. It's one of the very last problems. I'm going to talk about this more when we talk about taxes there a little bit, but so pre-existing condition is someone has been diagnosed with a serious ailment and is now looking for health insurance. Denied coverage. How do you handle people like that? So employers handle it. They have an open enrollment period. So what that means is if you have an ailment, you don't buy insurance, sometime in November, if you can make it, say you break your leg in February, if you can wait it out until November, you can apply for health insurance and open enrollment, and they got to cover you even with pre-existing. So all covered, even pre-existing, if sign up during the short open enrollment. Outside of that, you're not covered. So young people are really healthy. They have an incentive like, I don't need health insurance. Hopefully anything that happens to me, I can just wait until November, get back in the open enrollment and jump back in. Right? What did the Affordable Care Act say? You must buy insurance or you are penalized. And then what did President Trump do? He took that penalty away. So since taken out, and the penalty is small ready? But the ACA also has an open enrollment period as well. So you hear people talk about government and provided health insurance. The pre-existing is pretty huge. Because if you don't control for that, you say anybody wants a health insurance, they can buy it, then people just wait. And when they get sick, then they enroll in. Insurance won't work that way. It was interesting in the presidential debates between President Obama and Hillary Clinton. This is exactly what Hillary Clinton said. You have to enroll everyone or the system doesn't work. Otherwise, health people don't enroll and they wait to enroll until they need it. And so she proposed that. President Obama says, no, we don't need that. Then he got elected, and what did he say? We got to add this to Affordable Care Act. So he very quickly figured out what Hillary Clinton's made her so mad. She was so enraged. She was like, yeah, I told you. She had a much more experience with it than President Obama because she dealt with this during her husband's presidency. She was in charge of reforming healthcare. So she had already gone through all of this. So she knew exactly what she was talking about, but when you're on the campaign trail, being right doesn't help you. It's the sound bites. And what she was saying sounded much scarier than what President Obama was saying. So she lost the argument. But boy, was she mad. You could just see it on her face. Especially when he, right after getting elected, he went, oh, you know what? She was right. We got to do this. So how do you handle pre-existing conditions? So this open enrollment is the way employers and ACA handle it. Here's my solution. You can like it or not like it. I think we talked about it already, but I'll talk about it again. We talked about move to tax credits instead of tax deductions. What that means is everyone becomes covered overnight. There are no people not covered. So there isn't a selection of do I buy health insurance? If you've got a $2,000 tax credit that you can spend only on health insurance, you'd be stupid not to spend it because there's no incentive for you not to buy it. So my solution now, I would means test it definitely. It would even be a negative credit. So if you have no income and no income tax, you would still get a tax credit, but only to buy health insurance. Now I'm sure there's big problems with that, but get rid of the tax deduction, make health insurance that's provided by employers fully taxable, and then get those that are covered, get them a tax credit. You overnight have everyone covered. And that's the key with pre-existing conditions. So I'm going to add to this, not only uninsured, but especially those with pre-existing conditions. Now, maybe you have another solution. How do you handle this? Medicare for all, you would have to force everyone into the system. Otherwise, if anyone has a choice, and this is real key, we'll talk about this with group insurance. If someone has a choice to join anytime they want to, then they'll only join when they need it. If you could buy auto insurance and the second you buy it, everything's covered, including the accident you had yesterday, then you would never buy auto insurance. You just wait to have an accident. That doesn't work. So pre-existing conditions is a huge deal. I've heard politicians just beat up the insurance industry. You don't cover pre-existing conditions. Yeah, they don't because the system does not work. You cannot get it to work. Can you imagine life insurance? Yeah, I want to buy a $500,000 policy on my grandfather. Yeah, he passed away yesterday. I mean, it doesn't work. You can't get it to work. So pre-existing conditions in any insurance does not work. You can't buy the insurance after you need it. You have to buy it before you need it and before it's obvious you need it. So if you've just been diagnosed with cancer, but you've had no medical treatments, you still can't be covered because you know you're going to have all these chemotherapy, therapies and radiation, all that. All right, that makes sense. Is that clear? I'm not saying you have to propose this, but that's one of the advantages of moving away from the tax deduction. I actually think it's possible to go from tax deductions to tax credits and not have any impact on the federal government's deficit. You can structure it in a way that it's actually revenue neutral. The employee gets more pay because the employer, instead of spending $15,000 on health insurance, they pay the employee 15,000 bucks. The employee gets a 3,000 credit. I think there's a better solution. I'm not sure that's the best solution, but I think there's a better solution than what we're currently doing. Okay, shortage of doctors. This one's really, really simple. Use this article or the one that says shortage of doctors. Right here, insufficient number of primary care doctors. I'll just give you the page number, page 185. And I'll let you find that. That's a really simple article to get into. They even have a list. More than 100 million people today live in an area without enough primary care doctors. The problem is particularly bad in rural areas. 3 physicians for every 1,000 people. America is behind most wealthy countries. There's plenty of stuff in here to pull. Baby boomers, more than 2 out of 5 practicing doctors will be 65 or older within the next decade. COVID, there was a lot of people that COVID was just like war for these poor doctors and nurses and nurse practitioners and physician practitioners. They just got out of the business. So even the problem was a problem in 2019, but after COVID, it's just gotten much worse. The other part of this is the pipeline. And this is how you can actually fix this. Why do doctors have to go to school for so many years? It takes longer to train a doctor in America than in most rich countries, and many give up along the way. Future physicians must first graduate from a university. They must attend a medical school for 4 years. After post-secondary, they must complete residency. Specialist training may follow. It could take 10 to 15 years. There has been much talk on this. Do we really train them? You might say, well, that sounds bad not to train them as long, but other countries it's much shorter and the quality of the doctors is just as good. Another issue, and that might be in this article, is you get a doctor from Russia or from Ukraine or from India, really high trained, but they can't practice here because of all the requirements for licensing, and they're perfectly fine doctors. We make it very difficult for them to license. Oh, here we go, right here. They must sit for exams and complete residency in states regardless of the years of experience. So you got some great doctor coming from overseas, and we're not going to use them. So we got this problem. Obviously, the AMA loves this problem because it means doctors get paid more, but ultimately it's going to become such a serious problem they're going to have to fix it. So that takes care of that. All right, so that's all the articles. Got a few miscellaneous items at the end. We talked about players and incentives. So these are some notes in here. Just extra notes, overdiagnosis. Here's one thing on overdiagnosis. This is already organized for you. So for the first time in history, starting, I don't know, whenever employer provided health insurance started, before that, we didn't visit doctors if we weren't sick. Now we visit doctors just routine checkups. That was pretty rare. What's the problem with that? If you visit a doctor today, because of all this technology, they'll probably find something that probably was not going to do you any harm. I even mentioned colonoscopies. We usually say that's one of the best areas of medicine because it discovers things early. It's a slow moving cancer, but I got one of those TikTok videos. This guy saying, no, it's worse. It does more harm. He says 1 out of 1,000 people getting that test are actually very seriously harmed by the test. So it kills about the same number of people that it saves lives. So even on that one, the one that we say is a great test, even that one, according to him, I don't know how good his data is. According to him, it kills just as many as it saves. So how do we balance detection versus treatment? So when subjected to detailed screening, 86% has at least one abnormality. The average person has 2.8. People with no symptoms go in for screening, 10%. They'll find gallstone, 40%. They'll find knee cartilage. 50%, they'll find some bulging disc in the back. Here we have on the mammography, 1 death will be prevented out of 2,000 women getting them. 2 will be overtreated, including major surgery they didn't need. 5 to 15 will get early detection, but they'll still die anyway. And 250 to 500 are going to be just freaked out because they're told to come in for more tests. Lipitor helps 1 out of 100 taking the medication. It costs $1,500 a year. Here's where AI could really help. And you heard this in the video. People say, wow, screening saved my life. Maybe. You know, with prostate cancer, it's 1 out of 14 were actually saved. 13 out of 14 had unnecessary surgery. The other thing with overdiagnosis is the thresholds keep getting lower and lower and lower. Now, cholesterol has been big in the news. That cholesterol isn't bad. High cholesterol, and I saw one video, the guy said there's no relationship between high cholesterol and heart disease and strokes. I don't know how true that is, but this doctor said, I got patients with cholesterol at 600 and they're perfectly fine. So there's some debate on that. What's killing us is not the cholesterol, it's the food we're eating that the cholesterol is going to our veins to correct, to fix, and that's causing the buildup. But the cholesterol is actually saving our lives. It's just the thing that we cause the cholesterol had to come and fix. That's what's really killing us. Even the definition of being overweight, that keeps coming down. So I saw one article that 100% of Americans will be obese by 2030 or something. I mean, why? Because that government agency gets a lot more tax dollars if they say that. They have an incentive to exaggerate the problem, and so they keep changing the numbers. So we have more pre-hypertension, pre-diabetes, and these diagnoses don't show any noticeable reduction later on. So it's not helping. It's costing us money to put them in that category, but it's not actually saving any lives. Experts pushing lower thresholds are overwhelmingly the same way being paid by our pharmaceutical industry. I'm not going to take statins after everything I've heard on statins. I'm just going to avoid them altogether, but that's a huge drug. I don't know who sells statins. Statins. I don't know how to spell. Statin. It looks like Satan. That may be the right. Exitol. $20 billion annually. That's a good number. Everything I've read, I mean, you might have some grandparents, you might ask, Thanksgiving's coming up. This is a chance to ruin Thanksgiving. Find a way. The best way to do it is, we were talking about statins in my life insurance class. What do y'all think of that, or something like that? I don't know. Do y'all have grandparents on statins? Y'all know? Y'all probably don't know, right? So I mean, just Google it. Go on YouTube. You'll find all kinds of people saying they're not helping. It's a huge market though, so they have an incentive. Experts pushing this. Goal is not to find more cancers. The goal is to save lives. I forget what the lady said at the end of the video. I wish I could remember, but it was just the perfect quote. Focus on treatment versus prevention. As we talked about before, an overweight 55-year-old smoker, heavy drinker, doesn't exercise, bad diet. What do you do with that person? It becomes pretty obvious what to do. Although I'm changing my opinion on that. It really isn't calories in, calories out. That's not why we have a problem with weight in America. It really is the food industry. So I hope one of y'all will pick that as your extra topic, because there's so much stuff out there. I showed you that Dr. Bill. There's just plenty of stuff out there. So the food industry is out there to kill us because they make more money that way. So, but we're getting better at that, but it's not medication. The videos I'm watching is not medication. It really is. It is diet and it is exercise, but it's diet is what you're eating, not the number of calories, and it's when you eat. Those are the two things you're hearing right now. We have a bunch of billing codes, but there's no code for curing someone. How good is exercise? So we do have this section. Let me find our on American lifestyles. American lifestyles. While it doesn't help with weight reduction, diabetes could be cut in half, a 5 to 10% reduction in weight. So that's not going to come from exercising, but walking 30 minutes a day, drug reduce diabetes by 31%, exercise reduces by 58%, 71% of those over 60. That's the American lifestyle. It's not, we're not telling people, you know, to get your diabetes under control, go train for the marathon. That's not what we need. I've heard several of these TikToks saying, go walk 30 minutes after you eat, especially if it's high carb. It radically reduces the insulin surge. So yeah, reducing carbs is good, but you can do other things. You can do things like drinking vinegar right before you eat carbs. There's certain things that have huge impacts that have nothing to do with doctors, nothing to do with hospitals. It's pretty amazing the stuff we're discovering here. Aging America's 70% of healthcare costs is concentrated on these disease. You do have the baby boomer section. I don't know if we talked too much about that. It's at the very end of the problems. I guess I gave you one. So this is the idea of chronic, how do you spell chronic? Chronic conditions. Stuff that 100 years ago was killing us. Now they're not killing us. Now we're living with them for 20, 30 years. Chronic conditions. But again, these TikToks I'm looking at, boy, the number of examples I've heard of people not changing their calories, not changing their exercise, but changing the type of calories and the timing they're eating. These conditions are completely disappearing. So hopefully this spreads like wildfire. Americans over 60, 76% take at least 2 drugs. This one could probably work pretty well. These last 2 could probably work under the baby boomers. One-third of people who die have major surgery in the last year of life. 15% of terminally ill men have a very unnecessary and painful prostate screening. I mean, they're terminally ill. They're going to die of something. Why test them for prostate? Inconsistent costs and quality city to city. I'll just copy all those in there. Find the word inconsistent if you got to do a search. So for heart surgery, the deaths range from 1% to 18%. Reporting of the data are here. This function here, cancerous prostate gland is 76%. Best is 17%. Incontinence, 43%, 9%. Reporting the data, this is so amazing right here. Reporting of the data to the public. What do I have this under? Inconsistencies. Reporting of this. So a hospital having to report their error rates caused a 41% reduction in deaths in 1 year. Hospitals fight against release information, protect hospitals from having to report the data. So, and there's a simple solution right there. Here's, if you need something inefficiency encouraged, I gave you several of those, but hospital make an additional $10,000 anytime they mess up. You know, you leave a sponge inside of someone, you're going to have to bring them back, open up them again, and operate on them again. Healthcare costs for men versus women. We talked about that. How are you going to handle that? So we already got through that one pretty well. All right, so we're going to get into this with porters, but what are key measures that you as a consumer would want to know about a hospital? What about the bounce back rate? You're supposed to go home and be cured, and yet 90 days later, you got to come back into the hospital because some complication. How long are you staying for this treatment? Are you staying 1 day or 3 days? Remember, hospitals may have you stay 3 days, not because they need to monitor you, but because they have excess hospital beds. So remember, cities that have excess beds, the hospital stays longer. Cities with a shortage of beds, that stays shorter. Never event rate, sponge left in patient. You might think that's impossible, but there are stories of people having a foot amputated and they accidentally take the wrong side. That's pretty serious. Death after elective surgery, your infection rate, that would be used to know. Your safety culture score. Nurses are incredibly honest on these surveys. They actually tell the truth. One of the questions they ask nurses, would you have surgery in your hospital? Wouldn't you love to know the information? If 80% of nurses say no, would you want to go to that hospital? I tell you, nurses know more than anybody else. If you know a nurse at a hospital, that's the person you want to ask. They know. I have a friend that was a nurse, and the stories she would tell about the surgeons, it just scares you to death. Volumes. We're going to talk about this with Porter. More experience is extremely important with surgeries. There are, you know, we had the big Iran crisis in the 80s, late 70s. You look back at that story, the Shah of Iran, why did he die? He died because he had a surgery that was very invasive when there was an alternative that was non-invasive. He just went to the wrong surgeon, and we had a big revolution as a result. I mean, pretty amazing. Use electronic records, all this kind of stuff. These are the kinds of things you as a patient want to know. All right, we'll get into outcome-based, but on consumerism, people spend more when health insurance covers them, when it's not coming out of their own pocket. They're going to spend 25% more to see a doctor, 25% more, 33% more likely to go into the hospital when they're not paying for it. Forget where I put this under, but I think, oh yeah, under solutions. Let's put it under hospital checklist. It kind of goes in this section. One survey showed, so this is on surgeons washing their hands. One survey showed that before the video was used, only 6.5% of surgeons washed their hands. Once they knew the video was on them and they were being monitored, it rose to 100%, right? So it rose to 90%. That's freaky. Guess what I asked my surgeon when I went into the surgery? I think I told y'all that earlier. He was insulted when I asked him. He had a very patronizing smile. Oh, yes, I did. I could tell he didn't like that question at all. Private health insurance through insurance companies. Okay, you can look through this. We don't really need, I'm just giving you some information that might be useful. This is essentially telling you where do you get your insurance? Private insurers, Blue Cross Blue Shield plans. There were a lot of not-for-profits, HMOs. They're all so integrated now, it's hard to tell who's who. Employer plans. You have Medicare, which is 18% of the population, but it's the majority of the cost. So, and that's probably going up since then. What does Social Security cover? We don't need this for your paper, but Part A is hospital. Part B is physician visits. Part C is the Medicare Advantage, private insurance plans offered to Medicare eligible for healthier elderly. Part D is what President Bush added, which is the prescription drugs. And they try to, this is the thing. You got these senior citizens, many of them are quite wealthy, and the government is bending over backwards to save them money, which is costing the taxpayer more. I don't know how deficit Part D is, but it's great for senior citizens and it's horrible for you young people. So Medicaid covers 23% of the population, but lower percentage of the cost because they're younger people. That's probably gone up quite a bit since the Affordable Care Act. There's a CHIP program, and then the VA, which had some really bad press several years ago. It seems to have been a little bit overstated in some places. That's the most true socialized medicine we have. So if you got an uncle, he's retired military, complain about socialism, then say, hey, your healthcare is the most socialist thing in the United States. What are you complaining about? I mean, it's not Medicare, it's Medicare plus the hospitals. Everything's covered by the government. The hospitals, the insurance, it's all government run, just like the NHS and the UK. Here's some other readings if you want to get into this more. Y'all are watching this movie, or you watched this movie. This movie I did not think was as impressive, but there's another one there. Here's another movie. So there are some other sources that you can go into. But we made it 191 pages. So let's look at our list and see what we haven't put anything under. Yeah, we covered the tax pretty well. And efficiency, I think we covered that pretty well. Lifestyles, complexity of the system, inconsistency. Make sure you give a few examples of that. So uninsured Americans, all you need to do is just so easy. Just get the current percent and maybe a chart over time. This one is so easy, you can do it yourself. But the rate is higher in US, other countries. ACA did bring it down. That's the kind of thing you want to discuss here. But it's so easy. It's a percentage of uninsured Americans. You do have to say for healthcare. 8%, 7.6, 3.9. 2019, this is a good one that shows you that it's dropped quite a bit since 2019. It was really, really high before ACA, so I would try to find it before the Affordable Care Act was passed. Because it was probably, I think, 16, 17%. So it has dropped pretty dramatically. That's something President Obama can certainly take pride in. A lot fewer people are uninsured. A lot of people say the uninsured, these are people without a job, they're poor. But a big chunk of the uninsured are you people. It's young, healthy people who say, you know what, I just don't want to deal with it. I'm going to take the chance that I won't get hurt, won't get sick. So, so this is a good article right here. So you can certainly find that National Center for Health Statistics. That sounds like a great place to go, right? So I'll let you find that on your own. That's a pretty easy one to find. Yeah, I'm going to let you. There's some above, but mainly the movie. We'll get in this a little bit in Porter. It's called evidence-based medicine. You can actually find that pretty easily. It's a term that's used pretty commonly. There's even a video. There's even a whole class. So we'll get into a little bit, but you see it in the the movie, definitely. We covered this one already. The Safeway article. I just copy it over there. We covered this one, but we put it in a different section. So I tell you what we can do here, process improvements, move under lower cost models, just move it down there, all right? Y'all know what Six Sigma is? It's having a team going out and looking for ways to save money. We had those at USAA. All right. Here, what I'm looking for is just give me your opinion, but be consistent. Here's where students go really wild with this paper. So they say, we need to move to tax credits away from employer provided. We want to have more consumerism in this, so we have higher deductibles. Oh, and everybody should be covered by a single player plan. And it's, you know, which is it? You can't have private insurance, and people are incentivized to be consumers and also want one system for all. So here, I'm sorry, it's probably a spam call. What is WhatsApp audio? Yeah. On WhatsApp? Why would someone call me on WhatsApp?
Not from your grandma, she was running.
No. How do I put it on? I don't know. Well, Skype, I get those people, but I have no idea who they are, and I just delete them. Okay. So just give me your opinion, or this can be your extra work. You could say, you know, I'm not a big fan of government provided a mandatory single payer system. However, looking at Bernie Sanders' site, this is what he's arguing, and that could be your extra analysis. So you could come in and say, I don't like it, I don't agree with it, like the first two articles said, but let me talk about it. What is Bernie Sanders proposing? That could be that section, but just be consistent. Don't say you want private, high deductible, HSA, MSA, healthcare, but you also want Medicare for all. That's completely inconsistent, all right? So what some students have done is they just say, we need this, we need this, we need this. These are all the solutions. I'm not saying these are solutions. I'm saying these are potential solutions. You want to talk about all of them, but you don't have to agree with all of them, all right? So if you don't like my tax credit ideas, say, yeah, in class we talk about tax credits and how that affect. I don't think that would work for these reasons, and then you just slam it all you want to. I won't be insulted at all. All right, so be careful on that. Some of the papers are almost humorous because it's like one paragraph says one thing and the next one says the exact opposite, but they just want to cover everything in rubric, and it's a very, very inconsistent paper. We're going to talk about Porter next, and other is you choose, and by this it can be elaborate on one of the above. Doesn't have to be something completely new and different that we haven't talked about yet. All right, so we're almost there. We're going to talk about Michael Porter and then have one more book to cover. So we'll probably finish Thursday night. Let me show you Michael Porter real quick. It is dated, but it's still very, very good. I've looked at stuff he's done since this one, and this is his best one. I get this a lot. The first paper they write is really good, and then the next ones are just not as written as well. This one's really, really well done. Good old Michael Porter, you know Michael Porter from the Porter's Prize Forces and Value Chain Management. So he's actually proposing a fix. If you look at the rubric, wherever it is, this one has extra weight to it. Not paper one, sorry. Where's the healthcare rubric? Paper two, I don't see it in there. But if you look at the Porters, it's extra weight. I think it's like 4 with most of the rest are 1, so it's weighted 4 times as much. There's a lot in here. Really, all I'm asking you to do, and we'll go through it in class, there's some really, really interesting things in here, is to summarize. It takes most students about a page or so to get through it all. You put it into your own words, but it's very well organized. He says exactly what he's after, even as a chart for it. He has 5 pieces to his answer, and it's essentially discussing these 5 pieces. So we'll go through this. I don't want to start it now, but we'll go through this on Thursday. Are questions on anything? We had really just 2 things left on this paper 2, massive paper. Since you have paper 1 on due this weekend, I'll wait to show you an example paper maybe on Tuesday, so you can see how some have organized it. Most organize it just going by the rubric, just make sure they get everything in there. I don't know when I'll put paper 1 due, but I won't even start looking at them probably Saturday afternoon. So anytime by Saturday at noon is fine. I don't know what I put on Canvas. I've seen a few people. The ones I've seen are really strong papers, so hopefully that's everybody. But if you're worried, I'm going to be grading 1 class all day tomorrow. But if you need a call or email, don't risk it, especially if you're on the edge. Don't risk it. We covered it some last class. Any questions on paper 1? All right, so we got the last 2 things. This one's probably the most important one of the last 2 because you're essentially going to give me a 1 page, a page and a half summary of this article. It's a really good article. It's Porter's solution. I mean, you can just see it in the title. It doesn't say that might or could. It says that it will fix healthcare. So we'll walk through it. I wish I gave you a more current article, but this one really is still as current today as it was when it was written, mainly because not much has been fixed. So on the point we made early on, and I'm not going to copy and paste on this one, so you'll probably want to take handwritten notes or type maybe an outline of this paper as we go, so you can just bring it over to your paper or maybe in your outline. So, but you definitely, if you want me to stop so you can copy and paste, let me know. So as we mentioned earlier, this is not the US problem is that our healthcare is so expensive, but all of our other problems you're seeing all over the place. The whole world is struggling with healthcare, rising costs, uneven quality. So he's saying it's time to change. And here's his model. You definitely need this in your summary. The best outcomes at the lowest cost. He calls this his value equation. So it's not just quality. You could get the best quality in the world if you spend another $6 trillion. So it's not quality. It's and the way he defines it is what's of value to the patient over what it costs to give them that. That's what they're looking for. Achieving the best outcomes at the lowest cost. Move away from supply-driven healthcare, organized physicians, toward a patient. This goes right in your, that's be top front and center from what he's saying. Patient-centered system organized around what patients need. That's the key right there. Move from the supply side to the demand side. As again, that's what I talked about with my issue with the Affordable Care Act. The Affordable Care Act, it does have some positive things in it, but it's an entirely a demand side solution without doing anything about the supply side. If you fix the demand side without fixing the supply side, costs just go up. So he's saying fix the supply side by focusing what the demand side needs. Don't just tell demand side use more. You got to figure out what the system is doing for them. So it's a shift of focus from volume and profitability to patient outcomes. That's it, patient outcome. This is outcome-based medicine. It's a fragmented system. That's another thing he wants to talk about. More integration, which is probably one of his boldest recommendations. So he doesn't like that you can get services all over the place, fragmented, a lot of local providers providing full ranges of services. He wants health delivery organizations, these massive organizations that are concentrated in certain parts of the country, and everybody else just has to fly there, but it gives you high volume, high experience, high value care. So he says you gotta address how healthcare is organized, measured, and reimbursed. And every single one of these is massive. I don't know if y'all have noticed the healthcare industry. Something's definitely going on in the healthcare industry. So United Health. And look at that drop. CVS. Look at that drop that they just had. Walgreens. Boy, you can do year to date on look at Walgreens. It was a $25 stock. It's now a $9 stock this year. You're seeing healthcare. There's something going on, some big battle going on with healthcare. Probably a lot of it's Medicare related, but certainly this industry is struggling. Right. So what is his solution? And you probably want to put this chart into your paper. That's pretty straightforward. You just take a copy and bring it in. He has something called integrated practice units. You probably want to define that in the paper. The second one's somewhat self-explanatory. So we're going to go through each one of these. You can find some good quotes for each one and put some of it into your own words. Measuring outcomes, not in terms of hospital volumes, but in terms of what it's doing to the patient. We're talking about health. He said move to a bundle payments for care cycles. That's the one I think is the least likely to work. But essentially what it says is, okay, your medical group, you're responsible for San Antonio. You do whatever San Antonio needs, but the grading is going to be based on how healthy San Antonio citizens are. That's how your payment is going to be based on outcome for care cycles, integrated care delivery across separate facilities. That integration we'll talk about. And so some of these are highly related to each other. So moving away from, let's start at the top. Improving access to care, containing costs, and boosting profits have been a distraction. Access to poor care is not the objective. That's the complaint with the Affordable Care Act. If you don't do anything with the supply side, you just boost up the demand side. You're just pushing more people into a broken system. North reducing costs, if that hurts quality. Increasing profits is today misaligned with the interests of the patients because profits demand increasing volume, not better results. Healthcare, the overarching goal for providers as well as every other stakeholder must be improving, and this is a key word, value for patients. So when he says value per patient, how does he define that? Here it is, the definition. Value is defined as healthcare outcomes achieved that matter to patients relative to cost. That sentence should be in your summary of Porter. Value is defined. So he says up here, must improve value for patients. Value, you probably should just quote him on that. He doesn't just say health outcomes, but health outcomes that matter to patients, but it's got to be relative to cost. Very, very important sentence. And he says that this is going to achieve that. So performance-based reimbursement, outcomes for patients. Pressures are leading to more independent hospitals to join healthcare systems, more physicians to move out of private practice. So a lot of this is consolidating into concentrated groups. Fear might be somewhat what we have already. We think down in healthcare, health group being so massive, CVS being so massive. Do you really want that concentration? But that is part of what he's recommending. I forgot about the bottom line is technology to this whole thing. He doesn't really explain that too much. Here's another way you can word it: organizing around patient's medical condition rather than physician's medical specialty, measuring costs and outcomes for every patient, developing bundled prices for the full care cycle, integrating care across separate facilities, expanding geographic reach. So that's essentially, in words, a summary of what this chart is showing. Thing I don't understand with this article are the pictures. I don't know who drew his pictures, but they're kind of bizarre. All right, so let's talk about the first one. IPU is pretty critical to his. So the first principle is structuring any organization or business is organized around the customer. The healthcare that requires a shift from the siloed organization by specialty to organize around the patient's medical condition. We call such a structure an integrated practice unit. An IPU team made up of both clinician and non-clinical personnel provides a full care cycle for the patient's condition. You saw a little bit of that in the video. That one part of the video where people are sitting in a room talking about a patient. That's essentially what he's saying. There's people from every practice in there, not the surgeon that's going to make money operating on the person. You don't want that person driving it. You want to have a much more integrated group. IPUs not only provide treatment, but also assume responsibility for engaging patients and their families, providing education and counseling, encouraging adherence to treatment and prevention protocols, and supporting needed behavioral changes such as smoking cessation or weight loss. This is not what the medical community wants, because if you do that, people will be healthier and you have fewer patients, you have fewer customers. It's critical. The healthcare system makes more money if they do a bad job because they have more patients. If you change the way they're paid to how well they actually treat their customers, how healthy their customers are, that changes everything. How do you make a hospital group responsible for smoking cessation and weight loss? That's an interesting one. An IPU personnel work together regularly as a team toward a common goal, maximizing the patient's overall outcomes as efficiently as possible. Essentially, what you want the hospital to ask is, what is it that will make the patient the healthiest? If that is getting them to a gym versus giving them statins, then that's what you do. So they mentioned some, I think Virginia Mason might be in the movie. One or two of the ones mentioned in here are in that movie. So this gives you something for that little extra research you're supposed to do. You might look up one of these organizations and see how they advertise. If you notice something about them versus maybe the hospital, UCLA hospital, that they so badmouth in that movie, how do you contrast the two of them? The impact on value has been striking compared to regional averages. Patients at this particular clinic miss fewer days of work. Look at that, 4.3 versus 9, and need fewer physical therapy visits. In addition, the US MRI scans to evaluate low back pain has decreased by 23%. Better care has actually lowered costs. They've also increased revenue through increased productivity rather than depending on more fee-for-service. To drive revenue from unneeded or duplicate tests, the clinic sees about 23. So essentially what they're saying is, we're so inefficient, become more efficient, we can see more patients, we can have more throughput, we can help them better. So we can actually increase our revenue, not by increasing unnecessary procedures, but we're reducing unnecessary procedures and doing more actually value-added work. The clinic seats 2,300 compared to 1,400 under the old system, and it does so in the same space with the same number of staff. Whenever IPUs exist, we find similar results. Faster treatment, I mean, here's, if you want a summary, faster treatment because you can see more patients, better outcomes, lower costs, and improve market share in the condition. It's up in Seattle. I don't know if you go on our website, you'll notice any of that. So I don't know if you went on their site, if you noticed something just obvious that they're doing differently, but that's the one this paper is emphasizing. All right, the second one is measurement. I've heard some doctors that complain about this part because there are some hospitals that have started doing this. It's not easy. It's really difficult. First of all, the system's not set up to do this, so that's part of the problem. Is this is a huge IT issue. Also, doctors, when you ask them questions, they're extremely knowledgeable, very knowledgeable, and they're trying to answer simple questions, simply worded questions for something that's really quite complex. And so I was listening to some doctors complain, yeah, we're trying to move through this. It makes sense. We should be doing it this way, but it's really hard to capture the data the way they want us to capture the data. So rapid improvement in any field requires measuring. A familiar principle of management, teams improve and excel, tracking progress over time and comparing performance to the peers and those outside. Rigorous measurement of value, both outcomes and costs, is perhaps the single most important step in improving healthcare. You saw that in the movie at the end, saying we don't have data for anything, we don't measure anything, we're going in this blind. You can see that frustration. It's pretty amazing as much data as we have, especially with Medicare, that we're not collecting all of that information. The only true measure of quality are the outcomes that matter to patients. We'll talk a little about that. When those outcomes are collected and reported publicly, providers face tremendous pressure and strong incentives to improve and adapt best practices. The outcomes that matter, so here they are. They have a list here. You might want to summarize some of these. This goes under the second one. Mortality rate, that sounds pretty important. Degree of health recovery, functional level achieved, pain level, your ability to return to normal activities, return to work, process of recovery, how long does it take to recover, time to begin treatment, time to return to work, to physical activities, disutility of care or treatment. So these are the negative sides. Delays and anxiety, pain during the treatment, length of hospital stay, infection, pulmonary embolism, deep vein thrombosis. I don't know what some of these things are. Myocardial infarction, whatever that is. Need for reoperation. That's obviously pretty bad. Delirium. But what are those things you don't want happening to you that the hospital can do to reduce? Maintain functional levels after your surgery. Ability to live independently, need for revision or replacement. And then the long-term consequences, loss of mobility, risk of complete fracture, susceptibility or to infection, stiff knee, regional pain. So he's trying to come up with a list of what are those things that patients care about that they want you to measure, because that's what they're going to the hospital for. They're not going to the hospital to have an operation, they're going to the hospital to feel better. If they'll feel better without the back surgery, then don't give them the back surgery. So tier 1, so you can just see these, you've got tier 1, tier 2, tier 3. So that's explained in the notes here. If tier 1 functions, outcomes improve, costs invariably go down. If any tier 2 or 3 outcomes improve, costs invariably go down. So if you improve any of these, the patient's better off and it costs less. And you can somewhat see that in some of these, because some of these are mistakes hospitals make where they actually make money by making the mistake because they have to treat the patient again. But costs go down relative to the health of the patient. Revenues may go down as well, but if that's the case, they can see more patients because they don't have to readmit some of these patients. By failing to consistently measure the outcome that matter, we lose perhaps our most powerful lever for cost reduction. But again, it's not easy. None of these are easy things to measure. For a field in which high cost is an overarching problem, the absence of accurate cost information in healthcare is nothing short of astounding. Few clinicians have any knowledge of what each component of care costs, much less how costs relate to outcomes. Now, it's pretty amazing. Could you imagine Amazon operating like this? You think Amazon knows every penny, every worker, every process? When they do robotics, they probably have it down, out 3 decimal places. Healthcare, not. Even though healthcare has plenty of volume, plenty of data, Because it's so fractured, no one's comparing notes. It's very expensive. Here's something very similar to what you've heard some of the other articles. We've been able to hide our prices for years inside insurance products, but that's going to end as more and more people move into new high deductible products. We're going to have to be able to communicate exactly what are we giving to patients, employers, and insurers for their money. Most cost accounting systems are department-based, not patient-based, designed for billing or transactions reimbursed under fee-for-service contracts. I think, again, this is such a mess. You look at hospital billing systems, it's like almost no one knows what's going on. It's such a mess, so much volume, and the way things are priced, it doesn't make sense to the patient. We saw that when we saw some example bills. So determined value providers must measure costs at the medical condition, tracking the expenses involved in treating condition over the full cycle of care. This requires understanding the resources used in the patient's care, including personnel, equipment, and facilities, the capacity costs of supplying each resource, the support costs associated, IT administration, then the cost of caring for a condition can be compared with the outcomes achieved. But that is huge. If you took an accounting class on activity-based costing, the accountants are really far behind. They're not far behind because they're not intelligent, hardworking people, but the problem is rather massive and very, very difficult. So time-driven activity-based costing is really tough to do. You ask a surgeon, how much time do you spend on this or this or this? It's really hard to go back after a busy week, and most of them don't want to do that because they have, these are high-paid professionals. They want to spend their time doing medical care, not filling out accounting forms. Providers are achieving savings of 25% or more by tapping opportunities such as better capacity utilization, more standardized processes, better matching of personnel sets to tasks, locating care in the most cost-effective type of facility, all those type of things that make perfect sense in any other industry, but in this industry it doesn't make sense because of the way they're incentivized. So here's an example. Virginia Mason found that it costs $4 per minute for an orthopedic surgeon or other procedural specialist to perform a service, $2 for a general internist, and $1 for a nurse practitioner. And a lot of these cost differences, focusing the time of the most expensive staff members on work that utilize their full skill is hugely important. I had this issue. Boy, I had one boss, senior vice president. He was making 10 times more than I was. And he spent the entire day one day trying to calculate standard deviation on his calculator. And at the end of the day, I said, I can do that in 5 minutes and you can pay me your salary for today, because he took forever. And sometimes you have to stop and think, why am I sitting here doing this? I got an analyst out there that can do it. Hospitals need to do the same thing. You got a nurse practitioner, probably is going to do it better than the high paid doctor who probably hasn't done it in a while. But for the hospitals, stop and think that makes more sense. It's more efficient. When they're not incentivized to do that, they're not going to do it. But yeah, you can move a lot of this to nurse practitioners, to interns, to other people that you don't have to pay the full fare. Clinicians and administrators battle over arbitrary cuts rather than working together to improve the value for care. So we got to change the model, change the incentives. All right, so there's the data part. I think that one's pretty tough. I don't think it's the toughest one, but that's certainly very tough. All right, number 3, bundled payments for care cycles. Neither the dominant payment models in healthcare directly rewards improving the value of care. Global capacitation, a single payment, so that's kind of HMO kind of approach to cover all of a patient's needs, reward providers for spending less, but not specifically improving outcomes. So in the HMO approach, where you say, hey, we'll pay you this fixed amount, their goal is to do as little as possible. The exact opposite is fee for service. It couples payments to something provided the providers can control, how many procedures they provide, but not the overall cost or the outcomes. Providers are not rewarded for increasing volume, but that does not increase value necessarily. The payment approach best. So here you go. This is, I think this might be the craziest part of it. It sounds really great if they could get it to work. The payment approach best aligned with value is bundled payments that cover the life cycle for acute medical conditions, the overall care for chronic conditions for a defined period, are primary and preventive care for defined patient population, healthy children, for instance. So it's essentially incentivizing them for the outcomes, not for the volume. Same thing with the HMO. HMOs are not incentivized for better outcomes. They're incentivized to keep their costs down because they got a fixed fee. Payment is tied to overall care for a patient with a particular medical condition. Aligning payment with what the team can control, providers benefit from improving efficiency while maintaining or improving outcomes. Sound bundle payment models should include, all right, listen to this, severity adjustments or eligibility only for qualifying patients. That's going to be pretty tough to do. Care guarantees that hold the provider responsible for avoidable complications such as infections after surgery. That one probably could, because there's been many studies that show that you can reduce the infection rates if you just start reporting the data. Stop loss provisions that mitigate the risk of unusually high cost events, something unusual happens like COVID or something, and mandatory outcomes reporting. So here's an example. Walmart trying to encourage more efficiency. Walmart introduced a program which encourages employees who need cardiac, spine, and selected other surgeries or taken care at one of the just 6 providers nationally, all of which have high volume and track records of excellent outcomes. The Cleveland Clinic, that's another one. I can't remember if the Cleveland Clinic was in your movie. The Mayo Clinic, Mercy Hospital, Scott and White, and Virginia Mason. So they're holding these up as examples of hospitals that do really well in that particular type of operation procedure. The hospitals are reimbursed for the care with a single bundle payment that includes all physician hospital costs associated with both inpatient, outpatient, pre and post operative care. Employees bear no out-of-pocket costs for their care. Travel, lodging, and meals for the patient and the caregiver are provided. That's pretty important. You tell patients, or you tell your employees, you're going to save us a lot of money if you travel by plane 1,000 miles. Well, you can't tell them that if you're not going to pay for the plane. So that's going to everybody's got to sit down and do the math and figure out what makes the most sense, as long as the surgery is performed at one of those centers. So that one's interesting. That's one that's going to be fleshed out more, I think. I'm not sure you're ever going to get perfect on the data collection side. All right, the next one is integrated care. He's kind of already talked about this, but there are huge opportunities for improving value as providers integrate systems to eliminate the fragmentation and duplication of care and to optimize the type of care delivered in each location. To do that, the system has to know what it's doing. So the example I gave you is I need a blood test for 2 different doctors who never talk to each other, where I could just get one. That's a pretty simple one, but why can't they talk to each other? To achieve true system integration, organizations must grapple with 4 related sets of choices: defining the scope of services, concentrating volume in fewer locations, choosing the right location for each service, and integrating care for patients across locations. You see why he wants these massive organizations. So like if my oncologist and endocrinologist, if they were part of the same organization, they could easily talk to each other. Someone would integrate those 2 together, make sure it all lines up. But right now they're competing. They're small medical offices that are competing for customers. They have no incentive to talk to each other. I don't know what happened if I were to tell them, hey, y'all both need a blood test. Can I just do one? I'm not sure how they'd answer that. It would be interesting to see. Quest can obviously handle it. Maybe I should ask Quest to do that. A recent study of the relationship between hospital volume and operative mortality for high-risk types of cancer surgery found that as hospital volumes rose, the chances of a patient dying fell as much as 67%. You definitely want to get that in this section. That's the reason he wants to move these special care units, because of the high volume. You're often far better off traveling longer distance to obtain care at locations where there are teams with deep experience in their conditions. Less complex conditions and routine services should be moved out to teaching hospitals and the lower care facilities with charges set accordingly. So you don't need the best surgeon in the world doing the minor things. and you don't want a new surgeon doing the most complex things. So you match those up to the right location. Maxing the complexity and skills needed with resource intensity, which will not only optimize cost, but also increase staff utilization and productivity. Again, you gotta have one massive organization to do that because you have to coordinate all of the stuff across location and cross care. All right. I bet some of y'all would do this automatically. If you've got a 2-year-old with a serious medical condition, I bet you'll do some research on who's the best in the country. And I bet you wouldn't mind paying for the travel either. So I bet people will do that and go around the entire country looking for the best. The problem is finding out who is the best. Where do you go to get that kind of information? I showed you a few websites we talked about in the previous classes, which purport to do that kind of thing. Come to us, we'll tell you where the best place to go. But where would you go? Where would you start? So, but I bet most parents with a young child would say, hey, I don't care how much it costs. I'm going to go to the best place in the country. This one's also related. Superior providers, particular medical conditions need to serve a far more patients and extend their reach through the strategic expansion of IPUs. I don't think that's really a particularly new concept from its previous two. And then technology. Often technology complicates rather than supports integration. A value-enhancing IT has 6 elements centered on the patient, uses common data definitions, encompasses all types of patient data. The medical record is accessible to all parties involved in the care. The system includes templates and expert systems for each condition and medical condition. The system architecture makes it easy to extract information. Doesn't sound like an easy solution, but it's easier if you have one massive organization than if you have this dispersed out a bunch. So essentially what he's saying is all these medical offices, these doctors that have their own practice, he wants them shut down and they move to some massive system and become part of that massive system. He says providers that cling to today's broken system will become dinosaurs. That's what he's hoping. Reputations that are based on perception, not actual outcomes, will fade. So hopefully you got all that in your notes. You can see it's not that difficult to summarize it. You can definitely quote them throughout, but it's an important concept. If you want to add to it, you just do outcomes-based medicine, and all kinds of things will come up. Outcome-based medicine is, but what does the patient need? Let's focus on that. Let's not focus on what makes money for the hospital. And it looks like there's a few hospitals, few systems that are moving toward that approach, and the medical system is getting much more concentrated. We'll see if we really like it having 4 or 5 massive providers, and that's where we go for our care. There could be a downside to this. I do worry about CVS being a pharmacy, an insurer, and a medical provider of services, because you kind of wonder if they own the entire system. If their goal is to maximize profits, what does that mean for the patients? So it's going to be interesting to see. This calls it evidence-based medicine. That is different. Outcomes-based medicine is not evidence-based medicine. Y'all, what is evidence-based? Can y'all think of that from the movie? I think of evidence-based as really focused on certain procedures. Should you have back surgery or should you just go through rehabilitation? So you take this pill, so you take statins. Man, the number of videos, I should show you some of these videos. It's got me, I'll never take a statin, but yeah, there's no evidence, according to these videos, there's no evidence statins actually prevent heart disease or heart attacks. That's evidence-based medicine. That's a different thing, but it is somewhat related, because if you do evidence-based medicine, your outcomes should be better. What pharmaceuticals should you use? So you're trying to improve healthcare decisions by looking at the data. And as the movie says, the healthcare system is not good at it, probably because the data is so fractured all over the place. So think of those as 2 different things, but they are somewhat related. They certainly impact each other. So, and I would highly encourage you to become an evidence-based patient. Remember the mistake I made with my surgery. Doctor, tell me all the data you have. Will this surgery actually save my life? Or will it actually risk my life with more exposure to radiation and cancer? Become an evidence-based patient. If they don't have the data, you should say, why are you going to operate on me if you can't tell me this will actually, what data do you have that shows this is actually going to save my life? Yeah, I think I mentioned on the colonoscopy that, for every life saved, one life is killed just through the procedure. I don't know if that's the data or not, but that's the data I would like to have. I don't want to go through that again if it's not going to actually help me. So these are really good terms. They become more common. And then this last cartoon has nothing to do with the article. I'm not sure why it's in there. But anyway. All right, so that's I think that's 4 points when everything else is 1. So except for overdiagnosis, I think is 2. Any questions on that? All right, one last piece of data we'll look at. This book, I highly recommend it. Why Americans Pay Too Much for Healthcare. We're not going to do much of it, but you may find a few quotes in here that could be really, really quite powerful. I'm going to just do the green ones, but I do have others highlighted. Essentially what I did is I read the book and highlighted, and then I went back and read my highlights into a text capture. It did okay, but some of the words got messed up, but I think I fixed most of them. But there were some places where it would change a word to something that made no sense, but I think I got most of them. It's not on Audible, at least when I had it, so I had to do it in paper. And then what I loved about this book, which is so amazing, if you need to do a massive research paper on this, their bibliography is incredible. The bibliography is almost a third of the book. And it's just amazing. Every footnote, they have all these studies and books that they reference that are just, I got somewhat distracted reading the book because I go to the footnotes and say, wow, I want to read that book. I want to read that study. It was like, I'll never get through this book if I do that. So I finally just stopped, but it's extremely well researched. These 2 guys are with the Cato Institute. Cato, you may not like them from a political standpoint, but they do really good research. They're very detailed. They're very good economists. And so whether you like their political views or whatever, it's hard to argue with the data they're presenting. They're not making stuff up. I'm going to cover some of the yellow here. So here's their solution. To make healthcare better and cheaper, we must change the way we pay for medical services. If and when when consumers take charge, the American healthcare system will quickly improve. Until then, it will not. That fits really well as a quote under the consumerism side. One of those first ones under the solutions. Inhabitants of this universe insist on identifying root causes, the 2 most central. So you're going to see some common themes here from our previous studies. The 2 most central, which are the intrusion of the political process in healthcare spending and the over-reliance on insurance. Look at that right there. We've talked about that several times. And other third-party payment, like Medicare. So the systems become too political. We haven't talked as much about that one. The incentives that result from these fundamental errors render healthcare transactions financially opaque, often absurdly so. These incentives enable and encourage health providers for whom opacity is a boon to mistreat payments and to overcharge consumers and taxpayers. So there's really 3 things they're talking about here: the politics of it, the overuse of insurance, and the fact that the patient has no idea what they're paying for, and the system itself doesn't know what it's paying for, and that benefits hospitals because they're just making money and no one really knows what's going where. He talks about Singapore as a model. Again, that could be something for your extra research. Just go and look at what is the healthcare in Singapore. Singapore is a country city. Singapore. healthcare system. I think you would find quite a bit of stuff there. It is a universal healthcare system. So, I mean, think about this. This is Cato, people from Cato talking about Singapore. And, this is Cato, and they're talking about a universal government provided system. So even they're willing to go to that side. The government could add funds when necessary. Patients have control over how these dollars are spent, and funds become part of the person's estate if unspent. So it's kind of a government mandated health savings account, moving this direction to transform the incentives and send healthcare prices and quality in the wrong directions. There are 5 problems with the car. Okay, here's their problems. Political control, we talked about that. Insurance. Every time Congress does something, it sends the healthcare system more money. That's what the Affordable Care Act did. Third-party payment. In 1960, we spent only $27 billion. You can almost move this to the introduction. Had healthcare spending grown at the same rate as the economy, it would be about $220 billion in 2016. Just under 7% of the figure it actually was. In the early 1960s, patients paid about $1.80 out of pocket for every $1. By the end of the decade, it was $1 for dollar. Today, we pay 20 cents for every dollar shelled out. So in the past, we were paying more out of pocket. That made us more consumers. Today, we pay only 20 cents out. Prices are too high. Over time, controls were added on the prices that providers could charge, but there were no restrictions on the volume. So when Medicare says we'll only pay X, the hospital says, fine, we'll do twice as many X's as we were doing before. Medicare also has few quality controls. It pays doctors who deliver services that are unnecessary, unproven, even negligent. The Department of Justice had one of its best years, making fraudsters cough up $3.3 billion, but that very same year, they drained almost $100 billion. So we have people out there trying to fix the system, but they're only scratching the surface. Why all this tax favorability to healthcare? Why isn't housing or other, well, housing has its own, but why don't we do favorable tax treatment for other things? Healthcare quality is not job one, because providers are paid to deliver, are not paid to deliver great care. They are paid to treat patients, opaque prices. So what is their solution? They say it's full of good people. Their book actually shows that there's some pretty bad people in the system as well. But good people with bad incentives will not work. Hospitals learning to make more money. This is a great on that. And inefficiency is encouraged. Hospitals make more money by treating patients for deadly infection than by preventing them. Hospitals can make more money by treating patients they have harmed than by preventing those harms in the first place. If you want a good quote, I actually going to copy that one over. A good quote for inefficiency is encouraged. That would be a good one to do. I've got so many on that one already, though. Real similar to what you heard in the movie. I'm paid more when I harm my patients. It's a sad part of the industry. Doctors and hospitals learn time and again that what is best for the patient is financially bad for them. That's another great quote. We can rescue ourselves from the mess we have created by helping people buy medical goods and services and health insurance directly. That's what he's talking about. Get rid of insurance. Patients who buy things with their own money, comparison shop, they look for high quality goods and services that are delivered conveniently. So the question here is, and this is something you could certainly question in your paper, are consumers actually capable of doing that? Or is the healthcare system so difficult for us to understand because so many competing people debating one way or the other? Can consumers really make wise choices? There are a lot of other systems consumers make really horrible choices. I know in our industry, financial services, we rip off our customer. We saw that earlier in the class with Equilink products. And those are people who are comparison shopping, and they can't comparison shop because it's so complicated. So you have to kind of question, and that's been my question on consumerism. Yeah, that sounds good, more out of pocket, but will we be good consumers? Will we actually ask the right kind of questions? Are we capable of asking the right kind of questions? Providers may enjoy a local monopoly, but beleaguered patients can disrupt their cozy cartel by traveling elsewhere. By having heart surgery at the world-class hospital in India, the average American save enough money to live on for a year. The average charge for knee replacement, here's one for different. You could put this under medical tourism, or you could put it under differences in quality and care costs. The average charge for knee replacement in the United States is $57,000, but there's a place in Oklahoma, the operation is only $19,400, but what's the quality difference? If your insurance company is paying for it, why do you care? So then it comes back to Walmart tells you, you got to go to Oklahoma, or the insurance company tells you got to go to Oklahoma. And it may be the employer. Be careful on this, insurer versus employer. What's the insurance company doing? It's a pass-through. The insurer is a pass-through mechanism. Think about this. This is really important to understand incentives. It's a cost-plus model, just like utilities. Insurance is a cost-plus model. So if insurance costs go up because they have more claims, more patients, they're just going to increase their price and pass it on to the employer. So I really think the key here is more the employer. The employer's got to say, hey, you've got to insure, you've got to find ways to cut what we're paying for medicine so our premiums come down. If the insurer can just pass this on to their employers, their customers, it's not going to solve the problem. So I like seeing a Walmart or anyone else, Amazon, some of these internet entities getting into this, and they're saying, what do we have to do? Oh, they can go to Oklahoma City for $19,400, or we'll pay $3,000 to send them there. They'll get the surgery there. That's what we'll pay for. Insurance company, you've got to do that. We're not paying for you sending people for $57,000. So that's an important concept. Insurers should pay for highly complex and expensive procedures. Patients should pay for routine. That's back to our very, very first article. How do you put this in actuarial terms? What would you call this part? High catastrophe, hopefully low frequency. And what is this? Low severity, high frequency. Exactly what we saw in the very first article. Why does Medicare refuse to pay even though these alternatives are comparative bargain? Because the program will only buy something for seniors if the money goes in the pockets of healthcare providers. That's why you want more money in the pocket of the consumer. Because if gym membership's cheaper than $14,000 pills and they're paying for a big chunk of it, so you know, all I got to do is change the way I eat. And again, I don't think it's calories in, calories out. It's really the type of calories and the timing. But if consumers figure out, hey, if I do this, my diabetes goes away by itself. I don't have to take all these expensive pills. That's what you're trying to incentivize. But Medicare has no reason to do that because Medicare can only pay the healthcare system. They can't pay anything else. So they only have a hammer. And if all you have is a hammer, what are you going to do? Everything's a nail, and that's the way they look at it. One source reports that if all anti-poverty programs were replaced with a single cash transfer, the current spending levels per family would be $70,000. So you can ask that question, would the poor be better off? He eliminated food stamps, housing allowances. I don't know if he has public schools in there. He might. That would be a pretty controversial one. And instead, you know, we'll just send you $70,000. Which would the poor prefer? So it's a political debate, right? People say, well, if you give the poor 70,000, they're going to waste it. But studies have shown that's not true. The poor are actually really good with their money, but there's a percentage that aren't. You're not worried about the use of drugs or alcohol or whatever. But actually, when you give people cash, instead of giving them food stamps, you give them cash, they actually spend the money much more wisely. A single mother, a single father, or a family, a poor family, they're going to spend that money pretty well. They don't want their kids to starve or die any more than anybody else. But our system has set up these in-kind transfers that are extremely expensive to maintain. Some countries have tried this. India has a program where they have everybody on the system. They just send them cash through that. So there's been plenty of economic studies showing cash transfers are better than in-kind transfers. So you could say, you know, Government should only pay for those extremely expensive, high cost, low frequency things. Medicaid, Medicare, all we should do is we just send that money back and let people make their own decision how they spend it. Stop covering this through government central program. Congress, okay, this is something I might put under fraud. Congress accepted $3.3 billion in campaign contributions from farmers. The fact that drugs were patented doesn't explain how they were able to march in lockstep for so many years. All right, I'm going to jump to the green. Here's another example. Gilead argues, all right, this violates everything we learned in economics, but they argue that at $84,000, this drug is a good deal because it cures hepatitis C and reduces the number of liver transplants and other expensive medical treatments. But in competitive market, you don't talk about the value of it to the customer. In a competitive market, it's your marginal cost. Pepsi doesn't say, hey man, people could die of thirst. We're going to charge $18 for a bottle of Pepsi. Because if they don't have something to drink, everybody dies. That's not the way you think about it. It's a competitive market. Everybody's competing. Prices come down. Competition gives you great products at lower prices. That's the purpose of it. But pharmaceuticals are saying, no, we're saving people's lives. They should be willing to pay us a whole lot of money. That's not the way the competitive market works. In competitive markets, antibiotics are priced on the basis of what it costs to make them, not in light of the benefits they yield. Competition pushes prices down to their marginal cost, and the consumer enjoys the surplus. That is the difference between actual price and action. So if you don't argue that you should charge the highest price a consumer would be willing to pay, that's not a capitalist free market system. You want to push costs down because of competition. But that's what the pharmaceutical industry is saying. How much is your life worth? That's how much we should charge you. About half of the most transformative drugs invented in the last 25 years had their origins in research that was supported by government funds. The 72 cancer therapies approved during those years gave patients only 2.1 more months of life than the older drugs, but 11 to 12 approved were priced above $100,000 per treatment. Research shows that a medication's price has no relationship to how well it works. That's a pretty scary comment. $1 million contribution from a pharmaceutical company to a copay charity. Yeah, this is pretty hilarious and sad. Wow, these pharmaceuticals, they're donating money to charities so that these poor patients can buy drugs. Wouldn't it be great to donate money to a charity that the charity then takes that money and sends it back to you as revenue? Wouldn't that be a wonderful charity? Wouldn't you love to do that? You donate $100,000 and that becomes revenue to you a few weeks later. That sounds great. Enabling the donor to collect millions from Medicare. So let's help these poor people. We'll pay 20% of their cost because we don't, we get nothing. So now they donate 20% and they get the full 100% from Medicare because they have 5% of the cost. You can see this book is pretty damning. Yeah, that's an interesting one. All right, this one, there's someone here that are probably not believable, but I'm trusting them to have it correct. It sold for $2,300 adults, 38 times more than the competitor. 6 randomized clinical trials found this drug and the other drug were largely equivalent. Why do so many eye doctors use the more expensive drug? Because Medicare pays physicians a lot more for using that drug. If you're wondering why Medicare doesn't simply pay the same amount for the 2 drugs or require physicians to use the cheaper drug, the law prevents them from doing that. So again, what did the Biden administration did it actually fix this problem? You got 2 drugs at the same outcome. One costs 38 times more, but doctors make more money if they do the more expensive one. Medicare pays it either way. Who's the only one losing in this? The patient doesn't care because Medicare is paying it. The doctor loves it. The pharmaceutical loves it. Who's the only loser here? U.S. taxpayer, right? They're always the one who takes it on the chin. This creates a large incentive for cardiologists to implant stents. After reading this book, I'm not doing statins. I'm not doing anything starting with ST. I'm not doing from a doctor. Stents, even when they are not necessary, according to Bloomberg News, 2 out of 3 elective stents, or more than 200,000 procedures a year, are unnecessary. Stents confer no benefit. Patients who resume stents weren't likely to die or suffer non-fatal heart attacks. Unplanned are likely to die or suffer non-fatal heart attacks, unplanned, whatever that is, compared to those who only took medication. The final cost of implanting stents in hundreds of thousands of patients who don't need them, about $2.4 billion. That's just for the stents to calculate the total cost. You had millions and millions and millions on blood thinners and other medical monitoring. So again, this, ask your relatives at Thanksgiving, are you getting a stent put in? Yeah, you should read this book. Don't tell them it's, don't get medical advice, but encourage them, research it more. Again, this gets back to evidence-based medicine. Okay, doctor, you put the stent in. How many years does that add to my life? What does the data say? What's my chance of having a heart attack if I get the stent versus if I don't get the stent? That's so obvious to ask, but how many patients ask that? What do patients do? The doctor says, I need it, it's going to save my life, I'm going to do it. You got to ask those questions. So think evidence-based medicine is kind of all over the place here. So I talked about the employer, what about the patient? We've got to start asking questions. Doctors hate that. I wish I'd asked more questions. My doctor he hated any kind of challenge to his authority. I wish I'd switched doctors. I was too young and not paying attention back then. Ask questions. You have the right to ask questions, and if they can't answer the question, don't get the surgery or go get a second opinion, do something. Because the person talking to you wants to cut you open so badly because they make thousands of dollars if they do it. And if they can't tell you what it's going to do, it's pretty ridiculous, right? They can't give you the data. It's like, why would I ever go into surgery for that? Here's 2 doctors perform unnecessary, this is incredible, unnecessary but highly profitable cardiac procedures on 750 patients. The surgeries were thought to have killed at least 94 patients and to have caused many others to suffer strokes. So this is the actual fraud. They said the people in this industry, they're good people, they're just poorly incentivized. These are bad people poorly incentivized that are actually killing people to make money. I don't know if I highlighted one, but there's one pretty incredible one where Medicare found out, a whistleblower through Medicare, that there was a particular hospital or medical group that was doing these fraudulent services. Medicare said, we don't care, we'll keep paying. So this person went to the whistleblower law, which gives them, and then they get a percentage of whatever the government saves. So Medicare was forced to do something about it. They had to be forced to do it. So Medicare does this, and then a congresswoman in Texas passed a bill to keep Medicare from stopping payments to this fraudulent organization. And her argument was, yeah, they're ripping us off, they're doing unethical things, but we can't ask senior citizens to have to find another provider. That's too much work for them. So she passed a law preventing Medicare from actually cutting. You're a taxpayer. What do you think about that? That's pretty horrible, isn't it? But that's the logic. I'd rather rip off the taxpayer than have a senior citizen have to pick up the phone and find another provider than this one that's ripping off the taxpayer. The researchers hypothesized that mortality would be higher during the this one's almost hilarious. So doctors are having a conference, and so these researchers say, hey, this is great, because all the best surgeons are going to be at the conference. Let's see how much worse medical care is when all these high-paid doctors, the best skilled doctors, are at the conference. So they hypothesized that mortality would go up, bad outcomes would go up during the conference, and different outcomes would be largest in the teaching hospitals with disproportionately larger fraction of cardiologists may attend. To their surprise, patients suffering from heart failure or cardiac arrest who showed up at the major teaching hospitals during conventions fared better than those who came when the good doctors were there. And high-risk patients fare even better. I don't know what that tells you, but kind of scary. We talked about C-sections already. Oh, this one's, all right, sorry, man. I just want y'all to know what's coming out there. Am I getting too cynical, Stephen? All right, look at this one. So, are these good people with bad incentives, or these bad people with bad incentives? So this
this company came up with 100 milligram vials, and the accepted treatment protocol was to give a dilacin an entire vial once or twice a month. This produced 0 waste. The Vita didn't do that. Instead, the clinics gave 25 milligram doses more frequently because the drug only came in 100 vials. They bought the 100 vial, gave 25, and threw 75 away, so they could make more money off of Medicare. Does that sound like a good use of taxpayer money? So what did they do? Well, a whistleblower came in, and they turned them in. So Medicare changed it to simple $230 per treatment, not for the 100. They didn't get paid for the entire 100 as they got per treatment. So what did the Vita do? They switched from 425 injections to 100 injection. So these firms aren't stupid. Medicare is not stupid, but Medicare is overwhelmed with the volumes. You'll see that here in a little bit. You see how easy it is to game this system. And again, who's the loser? It comes down to this taxpayer. And that's part of the problem with the insurance and Medicare. So if you're going to do a Medicare for all, if that's going to be your approach, you've got to address these issues. How does Medicare for all address this type of fraud? When the taxpayer is like sitting there paying for everything with no control, no power, no say, and the people on the other side. Now think about NHS in the UK. The difference in NHS in the UK is the government is both the provider of the services and the insurance. So they control this firm that's the Vita, whoever it is. They're both sides of it. In the US, if you're going to keep the supply side as private firms, they're going to figure out how to game the system. And shifting it all to Medicare for all, I don't see how you fix that. But if you want to argue that in your paper, make sure you address that. A big problem with the American healthcare system is it pays providers well for doing the things that don't actually help patients. You should have a quote like that somewhere in your paper. That's under the efficiency. Inefficiency is encouraged. Back surgeries to relieve pain are in a majority of cases no better than non-surgical treatment. Yeah, this is back to the evidence-based. So if you look under the rubric, under the solutions, right here, study of effectiveness of treatments. So you do have a few quotes here. So here's a really good one. So back surgery to relieve pain in majority of cases is no better than non-surgical treatment, yet doctors perform 600,000 of these surgeries each year at a cost of over 20 billion. I know a lot of people get back surgery. It's pretty intrusive. It really knocks them out for quite a while. There are some that are needed. There's a friend of mine, he had real bad pain in his neck, and he did surgery. It seems like it worked really, really well. Would therapy work better? Who knows? But $20 billion, despite studies showing that arthroscopic surgery to correct whatever that is on the knee is no better than sham surgery and is much more expensive and invasive than physical therapy. Doctors perform the procedure more than 500,000 Americans per year at a cost of $3 billion. So again, evidence-based medicine. These are the questions you should be asking. Doctor, if I get this surgery, how does it compare to people who don't get it? Well, your pain will go down immediately. Yeah, but 5 years from now, will I be better off or worse off? I don't want surgery if I'm going to be the same place 5 years from now just to reduce some pain today. Lots of men die with prostate cancer. Relatively few die of prostate cancer. PSA-based screening results and small or no reduction in prostate cancer mortality and associated with harms related to subsequent evaluation and treatments. That's another good one for evidence-based medicine. I realize it can fit under overdiagnosis as well, so that's part of it. Overdiagnosis and evidence-based medicine are kind of hand in glove. If you get evidence-based effectiveness of treatments, evidence-based medicine, you will greatly reduce overdiagnosis. So you might start this section is to address overdiagnosis, because that's really where we're going here. A review of 10 trials involving 600,000. We've already talked about mammography. The problem is that
that the early, less reliable studies spawn whole industries. So there's evidence mammography doesn't work. I saw a video not too long ago, the doctor saying the exact same thing. But why do we do them? Because early studies that were flawed spawn an entire industry. Once you start an entire industry, it's inertia. It's going to keep going. Years later, when better research reverses initial studies, shutting down the industry is hard because so many providers depend on it for their livelihoods. This might be a good thing to put under overdiagnosis. I think that's a really important point. This chart is so good. Several of my students put it in their paper. It's a copy of the book, so it's not the greatest looking thing. If you want to make it look really good, you could easily recreate it in PowerPoint if you wanted to make it look prettier. So you could recreate it, but you can actually copy and paste this. But this is an amazing, I don't know if any of y'all figured out what the quote from the woman at the end of the video was. I'm gonna have to almost watch the entire video just to get her quote, and I have to give it to y'all. I know it's near the end, so I probably could flip to the last 10 minutes. This is evidence-based medicine. Only a fraction of what physicians do is based on solid evidence. It's not saying it's doing harm or not doing any good. We just don't know. From randomized controlled trials, the rest is based instead on weak or no evidence and subjective judgment. So 11% is beneficial, 24% might be beneficial, 7% are beneficial but cause harm, 5% are not beneficial, 3% are definitely harmful, and 50% we don't know. That's pretty scary stuff. That's 3,000 treatments. So yeah, you can see why that should go in there. This you could certainly put in the evidence-based medicine to see why it's needed. We need more data. So you could certainly do that. You could put it under overdiagnosed. Either one works. Very scary chart. But again, mammograms, you're going to pull some of that in there. Probably do more harm than good. The balance tilted negative because mammograms generate false positives. Primary doctors piled on. So when they said no more mammograms, what happened? Time magazine quoted this doctor. He was appalled and horrified. There's no doubt. I mean, right there, there's no doubt screening saves women's lives. Yeah, there is no doubt. That's not the question. The question is, how many women does it harm? So if you save 1 out of 1 billion lives, but you harm 3, that's the question to be asking. I'm always asking, does it save lives? Yeah, it obviously saves lives. Okay, but how many does it harm? How many does it kill? To recommend that women abandon that is absolutely horrifying to me. Again, no data. He doesn't provide data. He just says there is no doubt. He should have provided data as part of it. He should have said for every woman hurt, 3 lives are saved or whatever. He should have provided some data to prove his point. Again, pharma's donating money, 43% more than the second largest contributing industry. If you want to put this on their fraud, hospitals and nursing homes contributed 1.4 billion, physicians and other professionals 1.2 billion. This industry donates, this is a few years ago, $35,000 per legislator per year. You almost want to run for Congress just to get to 735. You'd have to pay for it for your election, but at least you don't have to worry about paying for campaigning. Yeah, and Congress plays the system as well. And this is kind of scary too. So, you know, the video we're watching with Dr. Phil had the food industry is in on this, but then the food industry donates a lot of money to Congress. Healthcare system's in on this. One guy was making the point that the biggest buyers of food industry is tobacco companies, and tobacco companies already figured out how to make their product, you know, make it appealing so that people get addicted. And essentially, they're trying to do the same thing with food. And then they got the FDA on their side. Congress plays the system. So that generated substantial campaign contributions for politicians and huge fee visions needed to. So what Congress did is they passed the bill. You can read it up here. They passed the bill that's going to really hurt this industry. So the industry donated money, and what Congress did is they didn't delete the bill. They delayed it 1 year. So guess what the doctors had to do the next year? They had to pay more money to Congress, so they delayed another year. And Congress goes, wait, this is a pretty good little game we have here. Let's just keep delaying this every year and we'll get all these contributions. So they need a new fix every year. Kind of sounds like they're causing dust. Had to bribe, their word. But Congress and the lobbyists had an interest in making the repeal process as profitable as possible. So, any of y'all want to move to Tuvalu and just be done with it? Smallest country in the world. Unnecessary medical care accounts for 30%. Here's the 30%. I'm going to put this under waste. I don't know how much we had under waste. That's one of the first problems in the system. We got some things under fraud, and you can definitely put that comment I just made from Congress could go under fraud. Unnecessary medical care is up to 30%. Some people say as much as 50%. With total spending now north of 3 trillion, that means Americans waste 1 trillion on healthcare in just 1 year. That's $400 billion more than it spends on national defense. We could triple our national defense and our health would be no worse off. We could cut our healthcare 1/3, put that money, I'm not saying I want a national defense, but you could do that and essentially wipe out China and Russia as far as their arms race. We can never catch up with that. And our health would be exactly the same. We'd be no less healthy. We actually might be healthier because of so many unnecessary treatments that are going on. We could reduce medical spending by 50%. So here's the 50% without doing damage to our collective health. Health policy experts know that we see at best only weak aggregate relations between health and medicine, in contrast to apparently strong aggregate relations between health and many other factors such as exercise, diet, sleep, smoking, pollution, climate, and social status. Cutting half of medical spending would seem to cost little in health and yet would free up vast resources. This gets almost back to that second article. You remember, what did he say, 1.3 billion or million that we spend over our lifetime? I don't know where this goes, but you can certainly put it on there, fraud and waste. Oh, we're out of time. Sorry. All right, we'll finish this one up. We have one more class on this anyways. We'll finish this up. There's really not that much more because they go much faster. And then next Tuesday, you're going to be full focused on paper 2.